Okay. The talk I'm going to give on weaning is a totally stripped down talk. This is the very minimal amount of information. I have different ones and I put this together recently. And so this is ultra minimalist. I mean, for fellows you need to know much more, but this is totally stripped down. So, and all I'm focusing on is what determines whether or not you're successful in weaning. And obviously, to be successful means that you avoid making mistakes. And with weaning, one of the major problems is obviously that the mistakes you make in weaning, probably more so than most things in intensive care, they lead to the death of the patient. And so you have to be particularly careful in how you approach it. So if we look in terms of a patient in the ICU, a patient is going to have a tough road between entry into the ICU until the patient is discharged from the ICU. And the first danger spot for a patient on a ventilator in the ICU is a delay in starting weaning. And that is one of the crucial problems where you see problems repeatedly. Because each extra day that the patient is left on the ventilator, he or she is exposed to numerous different complications. For example, ventilator-associated pneumonia increases by 1% for each additional day that the patient remains on the ventilator. And then, if a patient develops ventilator-associated pneumonia, the mortality associated with that is 60%. That's on average. Obviously, for the individual patient, it may be 100%. So just leaving the patient one extra day on the ventilator may seem very simple, but for a patient, it may determine life and death. So your timing of when you begin ventilator weaning becomes crucial. And basically, if you look at it in terms of what your job in the ICU is, that your job is really to try and get the patient out of the ICU, to steer the patient through the journey in the ICU without falling victim to danger spots. So how do you shorten the ventilator time? The answer is to start weaning at the right time and to use the right weaning technique. The first two randomized controlled trials of weaning techniques showed that 60 to 80% of patients who were ventilated for a week or more had the ventilator successfully removed on the first day they were evaluated for weaning. It's an extraordinarily high percentage. And so clearly many of these patients could have had the ventilator removed a day or more likely several days earlier. And this tells you that most physicians delay in the time of commencing the weaning process. And so basically it's understandable that their delay may be related to being very cautious in not wanting to expose patient to unnecessary risk. But of course you realize that your caution is in fact exposing patient to a very definite risk of prolonged ventilation and all the complications that go with it. The ultimate process that we're dealing with here is really cognition. How do doctors think? And the Nobel laureate Daniel Kahneman, who got his Nobel Prize for studies of basically decision making, and in his book that came out just about a little over a year ago, he points out that there's two different types of thinking, or that thinking employs two different systems. And system one, as he calls it, is fast, intuitive thinking. This is very effort-free, but it's also extremely prone to error. And the second type of thinking, which is the tortoise here, is forming the judgments based on deductive reasoning, where you're going through your thinking very systematically. For many clinical decisions, we're going to be using both of these systems, and we apply different systems in different circumstances as to which system we rely on. In his research, Kahneman has pointed out that over-reliance on simple seat-of-the-pants system 1 decisions, which would be kind of rules of thumb, or for example, in terms of weaning, where a clinician's kind of feeling is that the patient is not ready for a T2 trial. If you just have that gestalt in your body, well, that can lead to very large systematic errors. And so, you know, we all recognize that whenever we write an order, that we're making a decision. Commonly, people will take the corollary that if you don't write an order, then you're not making a decision. That might seem to be the case. In fact, that interpretation is fundamentally wrong, because every time that a physician looks at a ventilated patient, and if the physician doesn't write an order, in fact, the physician is making a decision. And the decision is that you're making is that the patient is not weanable at that point in time. So the purpose of the Weaning-Predictor Tests are by alerting an unsuspecting physician to a patient's readiness to tolerate unassisted ventilation, basically being able to breathe without the ventilator, hours or days before he or she would otherwise order a spontaneous breathing trial. A Weaning-Predictor Test circumvents the cognitive errors that Kahneman is referring to, the cognitive errors that are inherent in clinical decision making. Clinicians often forget that a Weaning-Predictor Test is a diagnostic test. It's no different than ordering a CAT scan. It's the same basic issues that are involved, or for ordering troponins or anything like that. So when you perform a Weaning-Predictor Test, you need to follow all of the laws that underlie the proper use of diagnostic testing. Another problem is with the use of diagnostic testing throughout every field of medicine, is that physicians have a kind of a monolithic perception of diagnostic testing. They say a test is a test is a test. That's all there is to a diagnostic testing. In reality, diagnostic testing has to satisfy two very different tasks. And that is, one is screening and the other is confirmation. So the purpose of a screening test is to pick up cases of a condition as early as possible. The purpose of a confirmatory test is to confirm an already strongly suspected condition. These are highly different. A good screening test requires a test with a high sensitivity. A good confirmatory test requires a test with a high specificity. A screening test should be done when your suspicion is low. So ideally where your pretest probability is less than 50%, where you're thinking that it's 85% likelihood that the patient can't be weaned. That's the time that you want to perform your screening procedures. And a confirmatory test is done when the suspicion is high. And virtually no test is good at both sensitivity and specificity. You're going to have to look at each test in terms of the particulars that it's being used. So for example, in the diagnosis of lung cancer, a chest X-ray is a good screening test, but it's a poor confirmatory test. The opposite holds for bronchoscopy. Bronchoscopy is a good confirmatory test, but obviously a very bad screening test. So a Weaning-Predictor Test is used solely for screening. For confirmation as to the weanability of a patient, we do the second step, which is a T-piece. And these are totally different types of tests, and they're done with totally different goals in mind. So the goal of a screening test, as I mentioned, is to pick up cases of a condition at the earliest possible time. So a screening test in the case of a weaning predictor needs to minimize the false negative results. That means a test that predicts weaning failure, but the patient actually succeeds. And it needs to maximize the true positive results. That is the test that predicts weaning success and the patient actually succeeds. So if we look at sensitivity, it captures exactly these constituents. Sensitivity is the true positive rate over the true positive rate plus the false negatives. So we published back in 1991 the original report on frequency to tidal volume ratio. And since that time, its accuracy in predicting weaning outcome has been evaluated by at least 27 different groups. And the average sensitivity in the 27 studies was 89%, and 85% of the studies reported sensitivities above 0.9. So in terms of the sensitivity, it has a very high sensitivity. And in fact, it's superior to most tests that we use for screening in other situations, such as, for example, a chest X-ray for screening for lung cancer or a stress EKG for myocardial ischemia. The sensitivities of both of those is about 0.6. Or for, say, an echo for screening for endocarditis, its sensitivity is 0.37. And for whatever field you are in medicine, you need to know the sensitivity of the main tests that you're using. I mean, you won't know the sensitivity of the tests that a hepatologist uses, but you do need to know the sensitivity of the major tests that you're using in pulmonary critical care if you're to apply them intelligently. An EBM task force on weaning recommended that clinicians would be better off to commence the weaning process with a spontaneous breathing trial and then use the first few minutes of the spontaneous breathing trial as a screening test. They say, as written down here, thus the initial few minutes should be monitored closely before a decision to continue, and this is often referred to as the screening phase of the SBT. Well, this puts the cart before the horse, and it goes against every principle of diagnostic testing to say that you begin with a confirmatory test, and then after you begin the confirmatory test, then you do the screening test. This would be analogous to saying that when you suspect diabetes, that you begin with a glucose tolerance test, and then as the patient is doing the glucose tolerance test, you ask the patient for a urine sample to do a dipstick. So it has everything totally backwards, okay? Obviously, as well as that, a spontaneous breathing trial is completely unsuited to being a screening test because, first of all, its sensitivity is unknown, and that's the crucial requirement in a screening test. And it's impossible to find out what is the sensitivity because to find out what is the sensitivity, you would have to take patients who fail a T-piece trial, then extubate them and see how likely it was that your failed test actually did decide that the patient truly was going to fail extubation. And so ethics doesn't permit you to do that. So it's impossible to figure out what is the sensitivity of it. Also, a spontaneous breathing trial typically, as we know, takes about a half an hour to 2 hours to perform, as opposed to about 2 minutes to measure F over VT. And so this further disqualifies it as a screening test. As well as that, proper monitoring of a spontaneous breathing trial places considerable demands on the staff because somebody needs to be around to look at how the patient is performing. Whereas measuring F over VT requires minimal effort on the part of the staff. And fourthly, the screening should be done where the pre-test probability, as I mentioned, is low. Ideally, really you want to do a screening test where your pretest probability is less than 15%. And again, if you suspect that the chances of a patient failing a T-tube trial is 85%, you're just not going to put in the effort of doing a T-tube trial. That's not the way you do it. So there'd be considerable reluctance for undertaking the laborious spontaneous breathing trial in a situation where your pretest probability is only 15%, but there's obviously no hesitancy in doing a simple F over VT where your pretest probability is less than 15%. Striking evidence of the importance of rigorous screening is provided by the randomized controlled trial performed by Lelouch and Brochard, where they were using a computerized system for weaning. And that computerized system is now built in to the SmartCare ventilator manufactured by Draeger, which is used in a lot of places. We don't use it, but it's used in lots of places. And with the use of that algorithm, you can see that the weaning duration was decreased from 5 days to 3 days on average. And what is happening with the SmartCare ventilator or with the Lelouch computer algorithm is that the computer is automatically screening for the patient's weanability at a point in time where the physicians are not obtaining weaning parameters because the pretest probability is very low. Again, physicians don't obtain weaning parameters when your pretest probability is very low. They wait for it to be higher, and that's what's happening here. But obviously, if you obtain your weaning parameters when the pretest probability is very low, then you would be able to shorten the ventilator time every bit as much as the SmartCare ventilator. So if you're making your measurements of weaning predictors when the pretest probability is less than 20 to 40%. The task force's recommendation to commence the weaning process with a confirmatory test, in addition, basically portrays a failure to comprehend the very purpose of the weaning predictors. Again, a weaning predictor is performed solely for one reason, and that is as a physician alert to cause you to undertake a T-tube trial sooner than you would otherwise do it. That is the only reason to do it. I mean, it's you're wanting to be proven wrong. It's your gut feeling this patient is not ready, but then you're doing the weaning parameters to prove yourself wrong. Obviously, if you find that in your own practice that about 80% of the time that whenever you do a weaning procedures in the patient or you're doing weaning tests, predictor tests, and most of the time they're indicating the patient is weanable, well, there's a clear message there. You're performing them too late. You shouldn't be having a high success rate in terms of the weaning predictors. If you're finding that most of the time, say 50% of the time, or higher, if it's higher, it's even worse, that you're finding that patients are passing the weaning predictors, then it clearly indicates you're too late. Okay? And so basically what you're doing, if you have a SmartCare ventilator, that'll overcome the problem, but most of us don't. And to me, there's little reason to do it. It's just that you need to operate in the same way as the ventilator is doing it automatically. The other point to keep in mind when looking at weaning predictors is that you need to treat patients, not to treat numbers. And with any tests, there is always a temptation that you will end up treating numbers rather than treating patients. And so if we look back in the original study that we performed, here you're looking at the failures are shown in the red dots, and the successes are in the blue dots. And you can see that the failures tend to have high respiratory frequencies and low tidal volumes, and that the successes tend to have higher tidal volumes and lower frequencies. And the value of F over VT that separates out the weaning success from the weaning failures was a value of 105. That gave the best separation, and obviously that's close to a value of 100. And so a value of 100 is on average kind of the value we take from separating out the likelihood of success and failure. But of course you need to tailor that number to the underlying characteristics of the patient. You shouldn't be locked into simply a value of 100 for every patient. And so in a research study, how we separate out how you decide what is the threshold value to use for a diagnostic test, you make that decision based on a utilitarian calculus, which basically means you balance the number of false positive results multiplied by their harm against the number of false negative results multiplied by their harm. And it's the sum of those two that helps you to pick what is the threshold. And basically for the individual patient that you're taking care of, you need to go through an analogous process in deciding what you do. And so, for example, if we have a patient with a neck fracture, then the physician may prefer to keep that patient on the ventilator for an additional day rather than risk weaning failure and reintubation, because reintubating a patient with a neck fracture is obviously extraordinarily risky compared with any other patient. So in that type of situation, you want to totally minimize the number of false positives. That's what you're really focusing on. And in that case, you would change the threshold from an F over VT of 100, and you would select a more cautious F over VT value, like an F over VT of 80 to 90. Because that would be the time that what you want to use in making sure that you don't risk unnecessary failure. The opposite is going to apply in a patient who is immunocompromised, somebody, say, a bone marrow transplant patient. Here, the physician feels that the risk of complications with mechanical ventilation far outweighs the risks of weaning failure or reintubation. You're very concerned about keeping the patient on the ventilator for one extra day. Then that could be a matter of life and death for that patient. And so with that mindset, the physician wants to minimize the number of false negatives, and the physician will be willing to undertake a T-tube trial even if the F over VT is higher than 100. Like if an F over VT is 120, and you say, this is where I want to decide it. So again, you can't just operate with a single number of 100. You're going to have to use your clinical judgment to know what is the right scenario to apply it. Okay. So that's leaving weaning predictors, and now going on to the weaning techniques. Basically, once you've decided on the basis of your weaning predictors that the patient is now ready for a trial of weaning, there's basically only two approaches that we use. We either use unassisted ventilation, which is a T-tube trial with no ventilator support, or other people, then we use a gradual reduction in pressure support. And in fact, around the country and around the world, probably more people use a gradual reduction in pressure support than they use T-tube trials. And this has changed over the last 20 years. 20 years ago, it was much more T-tube trials than gradual reduction in pressure support. And there's been a number of randomized controlled trials looking at this. And the two first randomized controlled trials, the first one was the Brochard study on the left. And this is sometimes felt that the pressure support is weaning the patient faster than a T-piece. And people often state that that's what it found. In fact, that's not what it found. What it found is that the pressure support was faster than a T-piece and IMV. Further statistics, the statistics only turned out to be significant if you lumped the top two together, if you lumped the IMV with the T-piece, which makes no sense. So there was no difference between pressure support and T-piece in their study. In the other study was the one that we conducted with people in Spain, and we found that the T-piece weaned patients 3 times faster than IMV and 2 times faster than pressure support. Okay. Obviously, the most difficult group of patients to wean from the ventilator are the patients who are requiring chronic ventilator support. And that was the focus of the recent study that was conducted out at RML. Okay. And in that trial, as you're aware, the study consisted of 2 arms. There was one arm was pressure support, and the other was trials of unassisted breathing using an oxygen delivery device connected to a tracheostomy or a trach collar. And the primary outcome in that study, and it was only powered to look at weaning duration. The study was not powered to look at differences in mortality. And I mean, there's no use in, if you do a randomized controlled trial, you need to look at right a priori, what is it powered for? And it was powered only for ventilator duration. And for this, the ventilator duration was significantly shorter with a trach collar than with pressure support by a very large amount, a difference of 15 versus 19 days. And here's the Kaplan-Meier plot of the proportion of patients remaining on mechanical ventilation with the 2 techniques, and you can see that they remained longer on the ventilator with the use of pressure support than with the trach collar. And when you use a Cox proportional hazard, which allows you to kind of compute out what is the odds ratio, as it were, or the hazard rate with the different techniques, you can see that the rate of successful weaning was 1.43 times faster with a trach collar than with pressure support. That's a 43% difference. So that's a very large difference in the pace of weaning with the 2 techniques. So one of the questions obviously that comes from this study is, why is the pace of weaning faster with a trach collar than with pressure support? And obviously the study was not in any way designed to answer the mechanism for the difference. But to me, in terms of understanding this, to me, I believe that one major reason for the difference gets back to the cognitive approach that physicians employ in how they're making clinical decisions. So during a trach collar challenge, the amount of respiratory work that's being performed is determined solely by the patient. If you have a patient on a trach collar, the ventilator can do absolutely 0 work. And there's a difference between 0 and a small amount. These are very different concepts, right? And people often think that they're the same, that 0 and a little amount is the same. No, they're vastly different. So obviously, if you have a trach collar, then a physician who is observing the patient through a trach collar has a completely clear view of what is the patient's respiratory capabilities. Everything you see in front of your eyes is telling you the respiratory capabilities of that patient. None of it can be coming from the ventilator. Okay?
Click on the bottom one.
Huh?
Click on the bottom one and then drop down, it won't keep popping up.
Where do you click on what?
Next time that alert comes up,
Yeah.
click on the bottom.
Okay, that'll do it.
It'll
Okay,
stop.
all right. Okay, obviously during pressure support, a patient's ability to judge weanability is clouded for the simple reason that the patient is receiving ventilator resistance, has to be, during the time that the patient is on pressure support. That's what it is. So, and then it becomes extremely difficult to distinguish between how much work the patient is doing and how much work the ventilator is doing. So it may be that the ventilator is doing a moderate amount of work. It may be that the ventilator is doing a large amount of work. And it may be that the ventilator is doing very little work. But of course, when you're looking at the patient who is breathing on pressure support, fundamentally that's the question you're wanting to know. How much work is the patient doing? And that's what you're trying to sort out as you look on the patient on pressure support, and simply you can't do that. Okay? So by physical examination and even by looking at the waveforms on the ventilator screen, it becomes very difficult. To me, it's totally impossible to estimate how much work a patient is performing in that situation. So this is a study, a separate study we performed back 10 years ago. And we developed a methodology to try and precisely measure what is the amount of work that a patient is performing while the patient is receiving pressure support. And we quantified work of breathing here by pressure time product. And the calculation of pressure time product is the orange shaded area here. And there's two types of, where do I click?
So,
how do I decide whether to change? No?
No, one up.
Keep the curtain color scheme and
Yes.
don't, yes, okay. Okay, all right, yep. So here we developed a methodology to calculate out the pressure time product. You can see it in the orange. And even on that, with even using esophageal balloons, it's very difficult, even with that, to calculate out what is the patient work. And in fact, what you end up doing is two estimates of what is the work. This is what we call the upper bound pressure time product and the lower bound pressure time product. And all you can say is that the amount of work the patient is performing is somewhere between these two orange areas. It becomes, even with the balloons, it's highly complex. So here is a tracing of esophageal pressure in a patient receiving pressure support. And so with the balloons in place, there's no way you can distinguish from the balloons what the patient is doing from what the ventilator is doing. It's completely impossible. And obviously our eyes are vastly inferior to an esophageal balloon. And so if you can't do it with esophageal balloons, there's no way you can do it with a human eye. And so when we calculate out in somebody on the ventilator when we're using balloons, what you have to do is you have to separately measure the chest wall compliance. And you measure that during passive breathing. And then you calculate out what is the chest wall compliance. And then you use that to calculate out what is the superimposed chest wall recoil pressure. And you place that on top of the esophageal pressure. Then furthermore, you have to be very careful at picking where is the precise onset of neural inspiratory time. You have to be able to find that. And so, because that's where the onset of inspiratory effort begins, and that's indicated by the solid yellow line. That's the onset of inspiratory effort. And then the offset of inspiratory effort is the dotted vertical line. So you have both of those. And so then that's how you calculate out the orange area for looking at what is the pressure time product. And so it's the difference between the esophageal pressure and the chest wall recoil pressure. And that's telling you the work that the patient is performing while the patient is receiving pressure support. And then we use the exact same methodology to calculate out what is the expiratory work. You go through the same type of process to calculate what is the work being performed during expiration. But to do these calculations for one patient, it took several days to do the calculations. And so obviously this is completely impractical for use for clinical management. And I'm showing you how complex it is to estimate the work that the patient is performing when you have all the methodology. And there is no way you can just stand at the bedside and say, I'm as good as this methodology just by my eyeball. And so again, judging the work of breathing during pressure support is really a fool's game. It's not possible. Okay? And so because of the impossibility of guesstimating the work of breathing during pressure support, clinicians are more likely to accelerate the weaning process in patients who perform unexpectedly well during a trach collar challenge or during a T-piece. It's the same with a T-piece, than when using a low level of pressure support. And this notion is borne out in the RML study by looking at the Kaplan-Meier plot, where you can see that the superiority of the tray collar over pressure support was evident within the first 10 days of the study. Then a subsidiary finding in the RML study was that of the 500 patients that were enrolled in the study, 160 of them passed the initial screening procedure, which consisted again of breathing unassisted through the tray collar for 5 days. So of 160 of the 500 patients did not develop distress during that first 5 days. And so these patients were categorized as weaning success, and they were not randomized into the study. Of course, that means that 1/3 of the patients who were transferred to RML, they could have been weaned at the home ICU without needing transfer. And of course, a fair number of these patients came from Loyola and from Heinz. So, okay. So this finding constitutes a damning indictment on the skill, or rather the lack of skill, in the ability of caregivers to use their thinking caps when weaning patients from the ventilator. These patients were being inappropriately imprisoned on the ventilator. So now moving to the last part. Extubation is strictly separate from weaning. You really should keep weaning and extubation separate, and they are separate, but obviously once you have weaned the patient, the next step is extubation. And again, at the point of extubation, there are further cognitive problems that occur that lead to major problems. So many physicians think that weaning is complete when they reach a pressure support of 5 or 7. And they'll often combine that with a PEEP of 5. And I think in the community, this is often referred to as 5 and 5. And people say this is how you wean people. And so once a patient reaches 5 and 5, the patient will be extubated from these settings. I believe that's extraordinarily dangerous. Okay, and in fact, the EBM task force sees that as a completely appropriate way. They say the SPT can be performed with a CPAP of 5 and a pressure support of 5 to 7. Okay, and part of this comes from the initial trials. And if you look at this, the rate of reintubation with the different trials, in our original study, for example, the rate of reintubation was equivalent with the different techniques. But of course, these RCTs were not remotely powered to look at catastrophes at the point of extubation. Rather, the powering of the studies, the number of patients entered into the study, was simply to detect differences in ventilator time. And because then there's no difference in the rates of reintubation, people assume that these all pose the same risks, whereas in fact the study wasn't remotely designed to test that question. I've become aware in the last few years of a number of patients who breathe very comfortably at a pressure support of 5 and a PEEP of 5 before extubation, but then shortly after extubation developed immediate cardiopulmonary compromise and irreversible hypoxic brain injury. And because of that, I wrote the editorial in the Blue Journal on it. Okay, and if we think of the factors in looking at patients at extubation, when you're assessing a patient for extubation, again, it's the same problem that we discussed in how you assess work of breathing while the patient is receiving pressure support. But whatever it is, before you extubate a patient, you have to get into your brain what you think is the work of breathing that the patient is performing at that point in time. And so if we compare the work of breathing in the extubated state compared with breathing before extubation, if you have the patient just breathing through the ventilator circuit where you set CPAP at 0 and pressure support at 0, the work of breathing for all practical purposes is identical. The problem is that when you set pressure support at 0, in fact the ventilator lies to you. You cannot set pressure support at 0. You dial in 0, but Puritan Bennett and Siemens, they actually deliver about a pressure support of 1 centimetre of water. If you ask the engineers, they'll tell you they're setting it, that's how they do it. So there's a tiny amount of pressure support, but fortunately it's very small. And so if you have somebody on a T-piece and you then extubate them from the T-piece, the work of breathing is virtually identical on a T-piece versus extubation. People often think that you're adding pressure support to overcome the resistance of the endotracheal tube. And that's what they think they're doing. That's a totally false premise. Because the problem is once you pull the tube, the patient is going to have to breathe through edematous upper airways. If you have a tube in place for even a half an hour, you develop edema of the vocal cords. It'll occur within a half an hour. You'll be getting changes that are occurring there. And it so turns out that roughly the work of breathing going through the inflamed upper airway is about the same as the work of breathing through a T-piece. So in fact, when you look at how somebody is coping with the T-piece, that gives you an idea of how they will cope with the narrowing that they will experience as soon as they're extubated. And so again, if we're looking then at somebody who is breathing on the ventilator circuit, not on a T-piece, so when we set them on a flow-by with pressure support at 0 and CPAP of 0, for all practical purposes, that's telling you the work of breathing that the patient is going to perform in the extubated state. But if you have somebody on a pressure support of 5, you decrease the work of breathing by 31 to 38%. That's just with a pressure support of 5. If you have somebody on a CPAP of 5, you decrease the work of breathing by 40%. And if you have the two of them combined, you're probably decreasing the work of breathing like about 60 to 70%. So these are huge decreases in the work of breathing. There's no pharmacological agent you as a pulmonologist can give to a patient that would ever decrease work of breathing by that amount. If you maximize out and you even overdose somebody on bronchodilators, you'll decrease work of breathing by about 10%. Here you're decreasing with a CPAP of 5, you're decreasing work of breathing by 40%. This is 4 times more than all your bronchodilators in the world. So this is a colossal change in the work of breathing. So when you're evaluating a patient's readiness for extubation, the single thing that you want to avoid the most is that you will be decreasing the patient's work of breathing while the patient is still intubated, compared with what the patient is going to face following extubation. That's the single thing you most want to avoid. Yet this is the single thing that most doctors do. I mean, to me, it's stunning that this is the case. Okay. What you want to make sure of is that the patient will be doing all of the work of breathing and that none of the work of breathing will be done by the ventilator. And obviously the only way to make sure that that happens is to make sure your pressure support is set at 0 and your PEEP is set at 0. So the thing is, if you look at the randomized controlled trials, obviously you see that many patients do perfectly well at being extubated from a pressure support of 5 and a PEEP of 5, because the vast majority of patients are well able to cope with an increase in work of breathing of 40 to 60%. They're well able to do that. But obviously, the fragile patient that you have may not be able to do that, and that's the key part. You know, when I wrote the editorial, there were people writing in who pointed out that obviously many patients in these studies, they found no problem in the rate of reintubation in it. And so, but the nuance here is that the challenge of clinical medicine is not about taking care of the great majority of patients who will do well irrespective of how bad their physicians are. Okay? And so, because obviously most patients will do perfectly well no matter how screwed up their doctors are, okay? Instead of that, what our goal is to take feasible steps that have a high likelihood of circumventing a catastrophe in a small number of instances. And that's obviously what we would want when we ourselves are a patient. We want to make sure that our doctor is going to be very careful to not expose us to all of the hazards. And so the people who responded to the editorial concentrated basically their comments on patient averages. And so this is a constant hazard in every aspect of medicine, in weaning and all of medicine, is that many physicians' thought processes are based on group data. And that's how we get our information from randomized controlled trials. Of course, they have to be obtained on group data. That's how you collect research data. But at the point where you are a clinician, you then have to take that group data and you have to apply it to the characteristics of the individual patient. And it's one patient at a time. And so if you look here at the 12 photographs that are shown here, you have a composite of the 12 photographs, which is the central one. And you can see obviously the image in the center bears no resemblance to the particular features of the 12 people that are surrounding it. But yet this is a merging of these to give you the summation image. And again, the job of internal medicine is that you have to customize the scientific knowledge that is obtained by averaging at the stage of research, but then you have to customize that knowledge to the individual patient and taking each patient as an individual. And again, in the correspondence, the letters related to the editorial, I pointed out that cardiopulmonary catastrophes are rare in weaning studies, provide no solace to family members of a patient who breathed comfortably at a low level of pressure support or PEEP immediately before extubation, and then was unable to cope with a 30 to 60% increase in respiratory load immediately after extubation, which led to a cardiac arrest and hypoxic brain injury. I've now been contacted by about 4 different cases where this has happened around the country. So to extubate a fragile patient directly from a CPAP of 5 or from a pressure support of 5, to me, is to risk killing the patient. It's an unnecessary risk. There's no need to take that risk in a patient. So to summarize this kind of the bare essentials of weaning, to me, to be more successful at weaning is to recognize that the primary challenge that is facing you is a cognitive challenge. And to recognize that all of us are inherently dilatory in how we approach weaning. We are typically very cautious and we delay in it. And so to avoid the delays that are inherent in the weaning process, you have to, when you see each patient, you have to ask yourself, why am I not obtaining weaning parameters today in this particular patient? On every patient, that has to be a question that you ask yourself consciously and answer. And then to recognize that a clinician's skill in driving the pace of weaning is determined by your ability to guesstimate a patient's work of breathing. And obviously your ability to guesstimate a patient's work of breathing is much simpler when you have the patient completely disconnected from the ventilator, because everything you're looking at has to be coming from the patient, nothing coming from the ventilator. Whereas if you have the patient on pressure support, it's impossible to tell what the patient is doing and what the ventilator is doing. And then before removing the endotracheal tube, you need to ensure that the patient is able to breathe comfortably for probably about 30 minutes on average in the complete absence of pressure support or PEEP. And all of these different challenges are basically consist of very careful thinking, and all of your thought processes need to be directed regarding the particulars of an individual patient rather than looking at patients on average, because you have to figure out what is special about this patient in making the decisions that are appropriate for this particular patient. Any questions?